focusing on a health condition, if I may call it, that afflicts largely women, but affects men. And we're joined in the studio. I don't want to describe what it is. I'll leave it to the experts to do that. But I'm joined in the studio by Tanya Nduati from the Flying Doctors Association, Society of Africa, and Dr. John Ong'ech, a gynecologist practicing at the Kenyatta National Hospital. We are focusing on something called fistula. Very difficult word, and I think condition as well. So, Daktari, let's start with you. What is fistula?
I think in simple term, fistula that we're going to talk about today is a communication between the bladder to the birth canal. So that means urine is leaking in the birth canal continuously, or a communication between the passage of feces or stool to the birth canal. So you can have a situation where now we call it VVF, when the bladder urine is leaking through the bladder, or RVF, rectovaginal fistula, when it's the feces are leaking from the rectum through the birth canal.
Right. So that is the condition we're looking at this morning. But of course, we've just not landed on this situation today, nor did we just choose it. We are discussing it because in the next couple of days, we are going to be focusing on it, and there's a project that is coming that, seeks to arrest or to handle or to treat people with this condition. So I'll ask you, Tanya, just to expound on what is coming ahead. I think it starts tomorrow, right? Why and what is coming?
Actually, we've been doing fistula treatment since 2006 as the Flying Doctors Society of Africa. We've been raising money to help women seek treatment because the costs of an operation like this are prohibitive. So this week, we are having a camp starting at Guru Nanak tomorrow, where women will be screened for 2 days, that's Saturday and Sunday, with operations beginning Monday through Friday. But this is just the beginning of a series of camps that we're actually going to hold throughout the country over the next few months to allow more women to actually get access to treatment.
So the screening is at Guru Nanak?
It's at Guru Nanak Hospital starting tomorrow.
Okay.
Yes. How widespread is this problem?
This problem is widespread, it's persistent, and unfortunately many people do not know about it, although in the last 10 years we've made some gains. We have about 3,000 new cases every year happening in Kenya, and in sub-Saharan Africa alone we have over 2 million women actually living with this condition.
Why does it happen? You are talking about leakage.
Yeah.
What causes this leakage?
This is a whole look at the whole women health issue. What I want to address is from the issue of safe motherhood. So what happens is when a woman is pregnant, then during labor, somehow we call it obstructed labor, the baby is not able to come out. Either the birth canal is small or the baby is too big. So then we get a problem with delay in intervening. Either the mother is delivering with the traditional birth attendant, so that problem is not diagnosed early, or if the mother is delivering in a facility where we do not have surgical intervention, or the referral to the next place where the mother can have a cesarean section to alleviate the problem. So it's a whole myriad of problems, but eventually the baby is not able to come out, so it causes pressure into the bladder and the rectum, and then there's a leakage. A bit of it also could be traditional practices. That obstruction could be FGM, some of the practices we do, early marriages, or malnutrition. If you look at the areas where the disease is very prevalent, maybe like in Northeastern, it's quite a big problem because of some of the traditional practices. So some of those things are some of the contributing factors towards this obstructed labor.
Would you say this is more prevalent outside, in the urban areas, rural areas where, delivery is by traditional methods?
Yes. If you look at urban vis-a-vis rural and places which I would call marginalized, then you probably find it more prevalent in those areas. It will be lesser in Nairobi compared to, say, Northeastern.
Yes.
Because of, yes, those traditional practices, the weak health system, and the poverty in general.
Right.
So, yeah, and, you know, those are places where, you know, this even stigma is high. So even if one has it, nobody talks about it. And
The truth, I suspect, is that a lot of people don't know they are suffering from what we are describing as fistula. Is it, in medical terms and the practice in this country, is it being diagnosed regularly across the country?
in terms of diagnosis, it's not a problem, but you're bracing a very important point that people are not talking about it. What would happen is if a woman goes to deliver and a man discovers that the woman now is leaking urine, leaking feces, what the story is that the man will run away or marry another wife.
Yes.
And then this woman is neglected and left suffering. And nobody talks about it. So it's forgotten. And that man moves on, new family, new children.
Yeah.
So that's part of the problem.
Yeah, so it's possible that really it's actually, you know, a lot more people could be having the problem.
Yes, yes.
But the way people in communities handle it is not like a medical condition.
Yes.
It's like a problem that arises out of childbirth.
Yes.
Those complications or the consequences of giving birth.
Correct.
I think is how people will be perceiving it. Which brings me to Tanya. Which,
Yes.
What is the outreach level you have undertaken that will tap these people to come for this, what you're calling screening? Because that's really the key. And should people travel to come?
We still face a myriad of challenges because the capacity is still limited. But now we feel that because we've gained a significant level of awareness, we would like to reach out more. The whole of Kenya is probably only able to handle about 700 cases. And here we are talking about 3,000 cases happening every year. And yet there's still a backlog of cases that have been there for a very long time. There are women who've stayed for many years. Last year, but one in Kenyatta, I met a woman who'd had this condition for over 50 years, since 1963. So that tells you there is still a lot that can be done. For us, we would like to join with as many organizations as possible and also work with all the stakeholders, the hospitals and the surgeons who are performing these surgeries, so that we can be able to have outreach, get to the hard-to-reach areas and do it continuously rather than doing it only in a camp scenario where we hold a few camps every year.
Yeah.
Yes.
Why would anybody want to stay with the problem for 50 years? I mean, apart from the stigma that we abandoned, is it not painful? Or
it's not fatal, but
pain.
some
But what
people
about
live
pain?
with it.
Yeah.
He's saying that many people don't even know they suffer from it. That's
Yeah.
the honest truth. You'll find women who will tell you that they actually think they have been cursed. When you meet them at Kenyatta and you're talking to them, when they come in on Monday, they actually don't even believe, when the camp starts, they don't even believe they will be okay. But somehow they hear the information and then they say, hata sikujua ni nini ilikuwa inaendelea kwa mwili yangu.
So what
So
what
they
you're
don't
saying
know.
is, what you're saying now is you're telling somebody who is suffering from that condition they cannot describe, or they don't know what it's called perhaps, or they're suffering from that situation, to come tomorrow to Guru Nanak.
Yes.
What are you going to do? What are they coming to do, or what are you inviting them to do if they have this situation?
We're inviting them to come to Guru Nanak to ascertain, to get screening, which will establish whether they actually have a fistula, whether they have a vesico-vagina fistula, like Daktari is saying, which is the continuous leakage of urine,
Yes.
or they have a recto-vaginal fistula,
Right.
which is the one where the stool passes through the vaginal canal as well.
Okay.
Yes.
Once they are screened,
Yes.
then what next follows in this project, in this camp?
If they are screened, then we will admit them into the hospital for them to go through a surgery, a reconstructive surgery, and then they'll have to be in the hospital for about 5 to 6 days, in which we'll monitor if the repair has actually been done correctly.
You have put together an army of doctors, surgeons, enough, how many to come and do this?
This is, we have at least 2 doctors that are actually going to be working on these surgeries this week.
They will not be overwhelmed. If we are making a call on national TV, come. From Homa Bay, from Kilifi, come to Nairobi.
We will not be overwhelmed because we will even continue to other hospitals and the other series of camps that we have scheduled
Yes.
to happen.
What is your target?
This year we hope to help over 200 women, together with the target that Kenyatta is handling of 250 women.
Okay, and this is all free, cost-free, or are they going to pay some amounts?
We will do it all for free.
All for free?
Yes.
Well, that's a great thing. Dr. How complicated or how long does a corrective surgery take to fix?
As I'm going to answer that, there's some question you asked there, which I just want to also address a little bit around the problem of the fistula, You talked about 3,000 new cases, and we are probably targeting 700 only. And a lot of this, I wanted to say something about it, because we are getting a lot of support from our developing partners, a lot. And there's little inside, the focus inside as a nation. I mean, Flying Doctor comes in looking for money elsewhere. But for us to really fix this problem, it needs to be like really top priority agenda, because prevention of this thing is critical in terms of resource mobilization and financing. It's still something which has not been so much prioritized in our health system. And I think if we do it, then we'll probably reduce the burden of what it's doing. And it's right now only a few hospitals can do it, like say Kenyatta National Hospital, which probably does 50% of the surgeries, more teaching referral. But if it is probably institutionalized and we have all the resources, we probably wouldn't be here where we are.
Yes,
now talking about, you're fixing me to the cure.
Yes,
I want to just make sure the prevention is very critical, because the prevention part of it, if people are aware, there's simple things that we can do, like even just once a woman has gone through difficult labor, a woman can just go with a catheter, put in the bladder, and within a month, that thing just heals. So there's a lot still we can do before you just go into the cure, which probably I just wanted not to lose focus of.
When that prevention you are talking about, you are saying people don't know. So then how do you prevent?
Yes, so that's what I'm saying. You've heard the efforts of the Flying Doctor, such as like probably leading, on this. But what are we doing as a nation? Beyond this, they are getting funding from the developing partners, to try to support this thing. So if this thing becomes our health agenda priority, and then we finance it properly and have a strategy, a policy strategy, prevention from community mobilization using our existing community health strategy, so that we reach every household, everybody's aware, just like HIV. People are aware about, if you talk about 3,000 new cases, you know that this is worse than even the new, almost worse than the cases that, this is high as even having things like HIV, those bad diseases, but nobody's talking about. So what I'm saying here is that it's putting resources, having a good strategy, policy support, and then a very, deliberate and organized approach, They are supporting this Guru Nanak camp now, which is coming. We do one also at Kenyatta National annually, which we do for the whole country. More teaching referral, that's something very useful. But if this is happening, it would be happening in the whole country, not only from the developing partners.
Yes.
We will be able to eradicate this thing. Media also doing their job like what we are doing here now. Then things will be okay. Of course, you ask me now the specific question on cure. Cure rate is known to happen. Once it's treated, over 95% cure rate is achieved once the repair is done. We have an example in Ethiopia, in Addis Ababa, where they have created a national fistula center. And they have treated over 30,000 women, and the rate of fistula has really gone down. But it's given a prominent and government supports it, and development are just coming to chip in. Not that developed partners are one driving agenda. Not that I have anything against developing partners, but I do feel that they should come in to subsidize. But we should drive the agenda primarily, put resources, because without money, without resources, you can't talk about skills and other things and addressing the problem. So Ethiopia, for instance, has been a success rate. A very nice national fistula center with good strategy, training people, going out there, awareness. Kenya doesn't have that. So if we do that, people will be aware, and I believe that we'll achieve a very good cure rate. So in terms of surgical skills, the people who are trained here are well trained. Once the repair is done, the cure is over 95%. Within 2-3 months, the woman is back to her life.
There's considerable public response to this discussion. As I said, one of the challenges is people knowing whether what you're suffering or your condition is called fistula, and then what do you do with it. But let's get it live from Mwakazi. What are the viewers saying? Are there questions or comments?
All right, thank you so much indeed. A very pertinent topic we're discussing this morning, and loads of responses here. Somebody just really appreciating. This is Dr. Nondi from Nakuru, says, talking about fistula, I would like to appreciate the work Dr. Hilary Mabea of Eldoret is doing, tackling the problem. And then, of course, others are saying, when are you coming to Mombasa? We have another one here. Any chance of getting to Nakuru anytime soon? Please give us contacts on where we can find you. Thank you. Now, let's get to the problems here now. Catherine from Nairobi says, how well does the medical school curriculum cover fistula? This should be targeted and should identify this problem at the time of contact. AMREF used to have a similar program some time back. I'm not sure if it still exists. Kindly carry out massive campaigns to share the information. All right, another concern here. This is, says, I'm Stanley and have this disease called fistula iano for some years, now operated thrice, 2006, 2009, 2013, November, and still in pain after visiting toilet and pulse coming out. How would you advise me to do? Okay, what to do? And then another one here says, hi, I'm Diana. My problem is that I don't go to the toilet normally. I have to take laxatives in it, and it's been 4 years now. Can doctor advise on what to do? And a final one here. This is, doesn't mention the name, says, I smell bad even after taking a bath. Might it be fistula?
Well, wow. I'll just ask the doctor and to respond. I hope you recorded some of those questions in your head.
Well, that's quite a myriad of questions, and I'll answer what I can remember. I think the work being done in North Rift by Dr. Mabea, really, I really acknowledge that. It's very commendable. He's very passionate about that. So everybody from Nakuru going towards North Rift, I think you're well covered with Dr. Mabea at Moi Teaching Referral Hospital. The other question about the curriculum. I want to talk about the curriculum.
Yes.
Yeah, I think at the teaching hospital, that is the Kenyatta National, so that's where the University of Nairobi Medical School is based. I think we've organized the fistula services such that as we're providing the care, we're also training our students, especially postgraduate who are coming out as gynecologists. But fistula surgery is a kind of a subspecialization. So you need to go for further training. When you hear the Dr. Mabeas, the Dr. Kisas, those lead fistula surgeons, they had to take another 2-3 more years to subspecialize. The only thing with it is that it's not paying. I mean, it's like a service to the community. It's different like when you go and subspecialize as a fetal-maternal medicine specialist and you're going to deliver babies all over Nairobi. Yes. It's much rewarding than going to deal with a poor lady from northeastern, fistula. So some of these people who you hear the names have actually dedicated their life. It's like a calling. Right. They have actually dedicated their life to this service, not to get a return, but probably God will reward them somewhere. Yeah. So, but in terms of training, I think the training, I can talk for the Kenyatta National Hospital. I think we have training. We have a theater dedicated for fistula, which runs every week. Okay. And students are trained there. But additionally, they have to go through further training, which I think Flying Doctors, AMREF, and other people do sponsor them to train in other fistula centers. We took them actually to Addis Ababa in Nigeria, which have very good training. So that's ongoing.
There was the issue of that lady who sent she had 3 for operations, and she's still not happy.
The fistula,
the fistula inano is different from what you're discussing here. What we're discussing here is related to childbirth. Now, the one they're talking about is a communication. You can have a communication between the anus to outside. It could be an infection, and then so a channel of things are coming out, but not necessarily related to childbirth. There are other things which can cause fistula in anus. So need to see a surgeon so that they can.
So that's what he says. What should I do?
Should see a surgeon. Should see a surgeon. So therefore, a corrective surgery. And also, this person who has chronic constipation, who is not able to go to the toilet, should also see a surgeon so that they can do what is called endoscopy or colonoscopy and check what's going on there. So sometimes other things can cause that, like it could be early cancer, tumor or growth or anything, or hemorrhoids or other things causing that. So they definitely need to consult a doctor. There were other questions. Were like,
somebody who's saying she was smelling bad.
Yeah. Well, I'm not sure about that. If the smell is coming down there, then that needs to be checked. But if it's a general body odor, then I think we may not necessarily say it's fistula.
There is another one who has asked, I have a girl who is 8 years old. Her urine has no control. Is that a fistula problem?
No, that's a sphincter problem. Yeah, and urine is controlled by a sphincter. Sphincter is like a valve, which controls urine, and it's a whole mechanism, voluntary, nervous system.
Right.
So that needs also to see a surgeon so that they can correct what is happening with the sphincters. Yes.
So it's not fistula. That's what that person is.
Well, it needs to be checked. I mean, if you can have an 8-year-old girl who has been sexually molested, and that is one way that the fistula can present after sexual violence.
Yes.
So I can't rule it out because I don't know all the history.
It needs to be examined.
It needs to be examined by a gynecologist, and then the truth established.
In fact, somebody asks, additional to that, does having sex at a young age cause fistula?
Yes, that's one of the major causes of the fistula, yes, because the birth canal is still not mature. And so, as I said, one of the causes is sexual violence. When somebody rapes a girl or young marriages, preteen marriages or those early marriages. So they actually cause it's a major cause of a fistula. Yes. Yes.
Yeah, a lot of interest in that. Somebody says, does it recur? Somebody says 6 months after giving birth, I have no control over urine, again.
That's almost like
what people not understanding what that like condition, how it manifests itself.
Yes, exactly. But like Tanya said, 80% of people think it's a curse during delivery.
Yes.
Yeah, so they just resign their life to fate, and so they just suffer.
Yeah.
And I told you the man moves on. With now polygamy being, it's almost a constitution. I always say
yesterday endorsed.
Yes. So I think they're like endorsing fistula to continue going on. I don't know.
I'll just keep, you have now become the doctor on air, so I'll just flash these questions to you. Somebody says, for the last 3 weeks, I've been going for a long call for like 5 times a day. And the stool is black. And he also has a problem of ulcers.
Yes, that's perfect.
Is that how?
That is called upper GIT bleeding. That person is having ulcer which has perforated. That is a medical emergency. So that ulcer is bleeding. So that's how the stool is black. That should go to the hospital now, isn't it? Because that thing perforated and can die tomorrow.
Right.
That is called medical emergency, upper GIT bleeding.
Yeah. Okay, that's a good one. You've got your answer there. And then somebody says, I have perennial, I think, tear, and I can feel the bladder protruding. Can you repair? Hey, he's 60.
Those are prolapse. Those are old age.
A man, I think, bladder protruding must be.
Maybe prostate, other things. Needs also to be checked up. You can see the health-seeking behavior of Kenyans.
Yes,
we're still a little below par. I don't know what's going on. Is it poverty
then someone says, are women who have undergone female genital mutilation more vulnerable to fistula?
Exactly. 100. Yes, very, very much vulnerable. In fact, if you ask the distribution of fistula in the country, Tanya will agree with me that Northeastern is almost on the very high side of the scale.
Okay. Right, we'll get back to that. But let me just let's get back to you, Tanya, about what is the Flying Doctors Society all about? Perhaps somebody wondering, who are these people?
I thought you were Amref.
Mutegi thought that's Amref. The Flying Doctor Service that I know. Which I think must be what you're associated with, and the Africa version of it.
I'll talk about the Flying Doctors Society. We are a fundraising organization, and we were started in 1971 to raise funds to help advance medical outreach across East Africa. So we're really the power that works behind the scenes to make sure that the doctors are able to get to these hard-to-reach areas. Right. And then we donate that money to implementing partners who are then able to then carry out the programs.
Okay.
So that's how we've been working.
This particular one, this
yes.
fistula camp
yes.
or screening and treatment and surgery, which other projects or diseases have you confronted or are you planning to? Historically, we've been dealing with specialist surgical services. So in the past, we were dealing with reconstructive surgery for urology, which now affects men. Yeah. And also we carry out charity evacuations for people who are in hard-to-reach areas who are not able to get to a hospital and may sometimes need to be ferried to Nairobi to come to hospital. We run a membership organization that allows people to contribute as little as 1,500 shillings a year. Right. That makes them members, and in the event that they have an emergency, they're able to get evacuated to a hospital of their choice in Nairobi. And if they do not use their membership within a given year, that is now the money that is then channeled towards these programs. So we've funded outreach to a tune of over 1 billion shillings since we were started. So every year we make sure that we provide access. Part of the training that Dr. is talking about on the Fistula program, we try to contribute some amount of this to help the doctors get funding in let's say, Ethiopia and you are going out
places.
to the rural areas.
And we want to go out.
It looks to me as if you describe AMREF.
No, we are Flying Doctor Society of Africa.
Service, yeah. Yes. But
AMREF is an implementing organization. We raise funds, we donate
to them.
Yes, but this particular program we are now doing on our own because we would like to extend the reach. But AMREF will also still be participating, but we will continue to give more directly to hospitals, say like Moi Eldoret Referral Hospital. We can be able to now work with Dr. Maber. Yeah. To also
this year you have given me 3 million.
Yes, I've given him 3 million to actually carry out surgery continuously.
You had something you wanted to add, I guess, and the flood of questions, we're coming to the end of the show, but just you had something to add before I put a couple of questions we finish up here.
No, I think she's addressed the big picture. I think I just wanted to echo the support we are receiving from them also at Kenyatta National Hospital. Yeah. This year they have given us 3 million shillings, and they have also helped us, infrastructure improvement. We have to renovate our theater, buy some equipment. So I think this support they are giving at the teaching hospital in Moi, and I hope it will just now cascade to our county referral hospital, because now we have a devolution. I know you are a specialist in devolution. I will be seeing
Not quite.
I hope Tanya can also maybe ask a question how we are going this in terms of devolution services. I think is what probably would be the way to go, because Kenyatta needs to be decongested. Moi teaching referral hospital needs to be decongested. So we need to think about the county referral hospital.
The level
level
hospitals.
Yes. So if she can't do it, somebody should do it.
Yes. We'll work together with
really,
all partners.
Yes.
Well, we're coming to the end of this show, but let me just put 2 final questions to you from, which I find pressing. Somebody says, I deliver, I have a growth around my anus, no pain. What could this be?
Anal growth could be many things. It could be, most commonly, it could be a hemorrhoids, which can be treated either medically or surgically. The simple thing that you need to see a doctor to look at it. There are many differential growths in anal.
So it's not fistula, so don't travel.
No, that's not a fistula.
That's the point. Don't travel, see a doctor.
Yes, yes, you're right.
There's another one who says that I can't hold my urine for long. This is Marian. This after giving birth to my 3-year son. Can that be?
That should become for the Tanya's program. If she's in Nairobi, that is the people we're talking about.
Tomorrow at Guru Nanak Hospital. As part of, you are actually the target of this program.
Yes.
I think I cannot go on more than that. Dr. We will open a clinic here on air. We will invite you and other specialists to do an air clinic one of these days. I just want to thank you, Tanya and Wati, for coming from the Flying Doctor Society of Africa, and Dr. John. Ong'ech
Yes.
from Kenyatta National Hospital, gynecologist, for us making time to come here. And tomorrow, the purpose of this discussion was that the fistula screening is happening tomorrow at Guru Nanak Hospital. If you have a condition down there that you cannot understand, or you understand what it is, show up. The treatment is free. The screening is free this week. Thank you very much for watching, and keep watching Power Breakfast.
Thank you.
Don't tell me you're now falling for Lorenzo.
I don't know what to say, Patricio.